Hi, how are you?
I'm fine, thanks. How you doing?
Okay. Um,
Are you presenting the other case or?
yeah. Had you gotten the email I sent earlier?
Well, I might have. I've been in clinic all day and yesterday, so I might have missed it.
Okay. I was wondering if there's any chance I could present first. I actually have a 1:15 meeting, but
Yeah, go
I
right ahead.
told the team that I could probably I would ask to present first and join that meeting late at about 1:30.
Yeah, go
Okay.
for it.
Okay.
Hi, Tim.
Hello.
It's
How are you,
Helen. Been a
Helen?
while. How are you?
Yeah.
Good to
Okay.
see you. What's the topic for today?
Challenging case conference.
Okay. Thanks.
Hello.
Hi, Anita.
Hello. How are you, John?
Good. I'm gonna go second.
Perfect.
Go from there.
Yeah, that sounds great. Thanks. Tim, we'll just maybe give it another minute as people are logging in, and then whenever you want to get started.
Yeah.
Go ahead, Tim, whenever you'd like to get started.
Okay, sure. Well, good afternoon, everyone. And I'm happy to be here for part of today's presentation along with John Barkham to talk about challenging cases. And this is one of the more interesting challenging cases that I had dealt with in recent months. Particularly from the standpoint of what transpired after the sleep study was completed. So to give you just a little bit of background, the little boy we'll be discussing today was studied in our lab in January at the age of 8 months. And he has a history of a rare condition called GNAI1 related neurodevelopmental disorder that's associated with significant developmental disabilities and risk for seizures. He had been hospitalized at Mott in late December, for treatment of bronchiolitis, and he was found to be hypercapnic and hypoxemic. He was actually on high flow oxygen at rates as high as 10 liters per minute, eventually weaned down to supplemental oxygen, 0.5 to 1 liter per night at home. And he was sent home, and an outpatient PSG was ordered to better characterize his respiratory disturbances during sleep. And the study was completed in January on the 20th. And the afternoon of the 21st, got a message that there was a priority study from the night before that needed to be reviewed. And so I quickly pulled up the study, and it showed some pretty complex and severe findings. And the PSG findings themselves are fairly straightforward, but it's the follow-up and the management that's the interesting part of this. So again, there's a standard PSG montage. You can see the hypnogram here, and right off the bat, we're just at sleep onset, and you can see that there's pretty significant hypoxemia here, and also hypercapnia. And although the study had not been ordered as an O2 trial, oxygen was very quickly added, and all of sleep was assessed using oxygen at varying rates, starting at 1/4 liter per minute to as high as 2 liters per minute. So to just kind of walk you through the key findings here, you can see very severe hypoxemia, SATs in the 50s and 60s. TCO2 levels typically in the 60s, and as we'll see, higher. Superimposed fairly frequent hypopneas, many of which had obstructive features, some of which it was not as clear whether they were obstructive or non-obstructive. And again, the oxygen has been ramped higher up to 1.25 liter per minute at this point. And you can still see we're running O2 SATs in the 60s and CO2 levels in the 60s as well here. And this went on for much of the night. Again, further advancements of rates. We're still running SATs persistently in the 70s, even between respiratory events. Our nasal pressure signal was not the best at many portions of the study, which also made it challenging to determine the exact proportion of hypopneas that were obstructive versus non-obstructive. And there was partial improvement by late in the study. So on the highest oxygen rate of 2 liters per minute, the periods of low SATs were intermittent rather than continuous. But we could still see on 2 liters per minute that SATs were at times lower than they should be. And again, persistent hypercapnia throughout the study, despite appropriate troubleshooting of the CO2 monitoring as well. And so during the study, the on-call fellow had been appropriately called. There had been appropriate adjustments to the O2, but when progress was not being made and the maximum O2 rate of 2 liters per minute was hit, the decision was made to call the MOVE team for assessment. This is a child who had been sick recently, had severe respiratory disturbances that weren't responding to O2 titration. And when he woke up, though, the SATs improved and things looked better. And our technical team did a very good job documenting in their notes and records and things like that some of the discussions when the MOVE team was evaluating the patient in the sleep lab. The MOVE team initially recommended that the child be taken to the MOD emergency department for further evaluation due to the severity of the DSATs. The parents expressed a lot of questions and concerns, not knowing what the evaluation would require. and were concerned that, you know, he might wind up being back in the hospital again. They wanted to know what a plan was. The MOVE team had, at one point, I think, suggested he might need an echocardiogram and cardiac evaluation, but then when it was found, when it was discussed that these were not available in the emergency department routinely, again, from the discussion, it sounds like the family was even more resistant to ER evaluation. So ultimately, the child stayed in the lab and the study was completed. Unfortunately, technician scoring was not completed until the following afternoon. And again, as many of you know, neonatal studies are not always the easiest to score. They do take time, and it poses some challenges there. But it was going to be late afternoon, and reviewing the study and things like that, and you can see the very significant respiratory disturbances. And let me just pull up the PSG report. And just looking at the numbers, HI rates at times exceeding 100 per hour, even on a 1 liter per minute of O2. The frequency of respiratory disturbances improved partially to 19 per hour on 2 liters of supplemental oxygen. But even on 2 liters per minute, there's an nadir SpO2 level of 59%. And this child spent nearly half of sleep time with low SpO2 levels, despite being on oxygen, and exhibited significant hypoventilation during both wakefulness and sleep. And so let me stop sharing, and because the rest of the discussion is really more about management and the like. So due to the severity of findings, and it was at the late afternoon, I paged the ordering provider with the preliminary results, even before the report was available. With the concern being, this is a child recently hospitalized with respiratory failure and infection. And the sleep study wouldn't answer the question, was this due to an acute process such as pneumonia or infection, or due to more chronic concerns in the setting of a complex genetic condition? And again, the study had actually been ordered by a hospitalist who did not know the family that well, but agreed with the acuity of findings that it warranted evaluation. He contacted the family, but then subsequently notified me that the family refused to come to the emergency department. That they wanted to know exactly what would be done, how this would be treated. And even when the discussion, at least my understanding was the discussion tried to include, well, it kind of depends on what the findings are as to what treatment is required and whether it requires admission or so. Again, the family had declined. And so we kind of expanded the scope of discussion at that point, because this is a child followed by multiple specialties, including pediatric neurology and pulmonary medicine. The child had already seen otolaryngology due to concern for airway obstruction. So we quickly tried to loop in the providers who knew this child well to be sure they were aware of the results and enlist their assistance in speaking with the family. And so we were successful in enlisting some of the providers who knew him to contact the family, who eventually agreed to come into the hospital, and he was briefly readmitted for further assessment. There had been assessments by both the medical team, I think otolaryngology, the pulmonary vent team. The concern was that this was not just simple, straightforward sleep disordered breathing. This is not a case of standard OSA where we sometimes get help with supplemental oxygen, but it was really more global ventilatory failure, and there was a worsening chest X-ray. And there was, I think, discussion of tracheostomy and ventilation. The family wished to pursue some second opinions before making decisions along those lines. And I haven't done a detailed chart review after that to see what's happened. But I bring this case up for discussion from for a couple of reasons. One, I think that the overnight team did a very appropriate thing in contacting the MOVE team for urgent evaluation. I think that was handled by the book, as we like to see if a child is not doing if his child is not doing well. But it's a less common scenario where we recommend evaluation, and it's kind of challenging to even get the child in for further evaluation. And that was the aspect of the case that seemed a lot less typical and posed the management challenges. I'd be interested in hearing others' thoughts on this case, or if others have encountered similar situations.
Tim, can you just say again what the underlying condition is that the child has? I don't remember what you said.
GNAI1 related neurodevelopmental disorder. Something like only 30 cases reported worldwide. It's extraordinarily rare. He'd had a history of seizures. He'd had some chronic respiratory and ventilatory concerns, frequent hospitalizations.
Did you say the patient also was hypercapnic while awake as well? Oh, okay.
Correct.
And in the actual, when he was just hospitalized, was his bicarb in his blood just elevated the whole time? Like, I'm just curious.
I don't recall all the details on whether or not it was venous blood gases or arterial blood gases, but I know the hypercarbia had been actively followed during the December hospitalization. That was a known concern that he was hypoventilating.
Oh, okay.
I think that this is also, I think, a good example of the challenges that we face. That I know our practice in the lab is that if there's, say, a treatment trial with O2 or CPAP, where we like to recommend treatments in our interpretation when possible. At the same time, I think there's a good example of a case where we have to be very careful in how we phrase those things, because the severity of his hypoxemia improved a little bit at the highest oxygen rate. But at the same time, it would not be appropriate in the report to say oxygen at 2 liters per minute is recommended, because he still had severe hypoxemia. His hypoventilation was no better. The frequency of hypopneas improved only partially. And again, keeping in mind the bigger picture, this is a child with respiratory failure and hypoventilation while awake and not just asleep. And so, especially for our fellows and learners, I would just urge you to be kind of cognizant of that in trying to find the precise language and expressing that if you have a study where there's partial improvement, be sure that we communicate that clearly, especially in complex cases.
Can you compare and contrast this with CCHS?
Certainly CCHS could present in this fashion. Again, this is a child with a rare genetic condition where we do not have at least at first glance, clear data to know for sure is this an intrinsic part of the condition, or to what extent is it appropriate to look for other things? There had been a recent hospitalization for bronchiolitis, so perhaps a legitimate question, how much could relate to current or recent respiratory infection? But again, you know, one of the downstream things to think about is, well, is it appropriate to consider expanding the search because CCHS is testable? Could there be two things going on rather than one? And I must confess, I don't know the extent of his genetic evaluation, if the evaluation would have covered CCHS or not. Fazia, you mentioned something in the comments. Did you have any other comments on the case?
So I think there may be an acute process, but the chronicity of it and the degree of hypotonia that this child has kind of makes CCHS much lower on the differential, because CCHS kids are typically not hypotonic, and the hypercapnia is not, like, the hypoxemia and the hypercapnia are almost in parallel. So that is a little against it. And then seizures, while it can happen, but are not a typical finding, like this child has seizures. And so those are a little bit different in a typical presentation of CCHS. This child also doesn't have like the apneic, he has obstructive apneas, but not like the true central apnea. So there's a little bit of a contrast with CCHS. And I think the whole exome sequencing that was done with this child would have found the mutations that would also kind of cover CCHS as a also in that spectrum, like we would have detected CCHS. It was challenging because right now as a hospital, we're completely full, and this family was stuck in the ED for like almost 48 hours with this child in there. And then what was mudding the picture was they were seen by otolaryngology before all of this, and there was some thought before the severity was known that, oh, maybe we could do adenoid removal, and the parents really got fixated on that point. So it was when we go in and talk about, which is a huge deal to all of us, is let's talk about trach and vent, which is I think a onerous task. And to bring that up, I think literally spent an hour and a half in the family room, like a pulmonary spent 2 hours. We went as a vent team, spent an hour plus. Parents were completely, like, we thought we were coming in for a plan to do it now. You're talking about trach and vent, which takes months of getting admitted, going through the process. Like, they literally threw a fit. So it was challenging. And so obviously they wanted to just have a second opinion, which we all concur, like you should get second opinions. And so the ultimate plan was send you home on oxygen, increase the flow as much as you can support it, and then kind of go from there. Just realizing that and give them the risk versus benefits. Like if you have an older sibling at home, if you come in respiratory failure again, and they're very hung up and very annoyed with the ENT as to why they wouldn't do surgery, but the risk is, if you do surgery, it is intubation. If you won't be able to get extubated, and you may think about a trach emergently. And they were like, it was a lot of discussion. So it was quite an interesting 2 days.
Did anybody find anything on GNAI1 and sleep apnea? I'm just looking, during the talk, and all I can find is that there's some reports of sleep disturbances, but I don't see hypoventilation. I don't see sleep apnea.
I think we did an OMIM search, and it was sleep disorder breathing. This child is a very severe case. Much more on the severe spectrum than typically noted. So I think, if I'm sorry, it's been a crazy couple of weeks. I think there was only one more with a neonatal presentation of similar severity, but not much known out there.
Severity of the GNAI1 symptoms or
GNAI1 symptoms. And it's somewhat of a variable presentation, but I think just the age of presentation in this kid was in line with like the hyperventilation, the hypotonia, kind of push it towards the hyperventilation and chronic respiratory failure.
we're going to do a case report, do you think, or you don't know?
We would eventually if we knew which way the child went or what was going on, and then where the parents chose to follow. They wanted to go to, I don't know how they got Cleveland Clinic or Mayo Clinic, and we recommended actually doing maybe CHOP or Cincinnati as a more reliable, because they are more like at par in terms of sleep and pulmonary care. So we actually recommended those two places, and we'll see what they chose.
Tim, I have a question. The study you presented, that you showed us was a baseline for which O2 was emergently added. Is that right?
Yes, yes.
At what point would you consider emergently going to PAP or to VAPS or something like that? I'm just curious.
Well, again, at 8 months of age, that wouldn't be an option in the lab.
Right.
You know, the other thing is in these cases about deciding about an emergency. Yeah, I always ask myself, is this or is this not what's been going on for the last 7 nights at home or 70 nights? Now, in this case, there was a recent hospitalization, right? So you can't be so sure that it's the standard, but the parents must have thought, oh, this isn't any different from the previous night. What are we doing? You know, how come everyone's ringing all the alarms?
Which is very true, Ron. The parents exactly were like, well, this has been going for a while. Why did we have to come in emergently to the ED? And they were quite annoyed with all of us. Yeah, and so the question is, should we have gotten them into clinic and talked to them about it and get it in a more controlled fashion than rather than having them wait in the emergency department, which is not a pleasant place for anybody nowadays.
At the same
Oh.
time, though, that course did allow the patient to be quickly assessed to be sure that this was not a worsening respiratory infection, which could have wound up with a different course of treatment. We were also limited by the fact that tech scoring was completed near the end of the day. If this was something that had been completed in the morning, there are times where, you know, there can sometimes be the option of seeing a PCP or somebody who knows the child well, but we were closing in on 5 p.m. You know, by the time that I had paged the referring doc.
Well, it must have been flagged as a priority study, no? Usually scored first.
Yeah, that's why we were surprised to get the call mid-afternoon.
Well, our policy says it is to be scored the next day, so it was scored the next day. Tim and Fazia, are there any biomarkers that allows us to gauge the severity of the case? For example, is there arrhythmias that would potentially be relevant more, or bradycardia occurring during these episodes? Or some kind of a ventilatory response, whether hyperapnea or bradyapnea? Is there something that would guide us one way or another?
Guiding us with respect to cause or treatment or both?
Both, meaning how to prioritize this, meaning in the sense that allows us to, because like you said, we are not there, but the text can potentially be vigilant about it. So that from an educational perspective.
Well, again, I think it's telling that it was nearly 50% of sleep time with SATs under 90% despite being on O2. So this child was, you know, severely hypoxemic, and that would seem to signal pretty, you know, high priority for urgency of scoring.
No, it's not about the urgency of scoring. And Tim, my question is like Ron said, that this might have been going for weeks, months, or whatever days. But what would alert somebody that, hey, listen, this might be going on for a week, but there is an additional component that, hey, there is something else going on additional that may be even more relevant as well.
Are you talking about the bicarb that sometimes we pick up on, Neeraj? I think,
Bicarb
right,
or tachypnea, or
yeah.
is there bradycardia that potentially happens?
Sometimes we pick up on the bicarb, which we use as a like rising bicarb, and especially in some children, we've seen like bicarb of 35, 36, and steadily rising, being a indicator that there is chronic respiratory failure. Sometimes we've had some of them with the bicarb like not detectable or 40 in the absence of being on diuretics. Like diuretics will push it up, but if they're not on diuretics and you see a steadily increasing bicarb of 35, 36, that is a poor prognostic indicator. And then if you see tachypnea, like the child is breathing in the 80s or 90s, though especially in an 8 or 9 month old, especially 90 to 100, those would be poor signs, especially if they're hypotonic. Those would not be reassuring signs for us.
Thank you.
Mm-hmm.
Okay, so thank you all for the good discussion, and hopefully we can turn things over to John Barkham on time.
All
Great,
right.
thanks so much, Tim.
Can you guys see my PowerPoint?
We can, thank you.
Shut off my heater here. All right, so this is a case that kind of outlines probably the more sophisticated patients we have in the sense of problems. This is a lot of our female patients present with a lot of different issues. So do our male patients, but this one struck me more as what we often see, and not every aspect. But so I got this consult back in 2020 during the COVID rage, and I got it from bariatric surgery. The reason for the consult was she had a stop bang of 6, likely sleep apnea, and acid reflux at night. And usually the arrangement with bariatric surgery is that, they will not do the surgery until the patient's compliant with their CPAP. I don't know how it is with you guys at U of M, but that's the arrangement we have. And it usually takes like 6 months to get in with us, and then she no-shows to the consult. So I, just sat there and did all the prep work. Do the fellows, do you guys do e-consults? Would this be considered something you might e-consult on?
We don't do e-consults. We just take regular like inpatient consults.
And if they no-show, like but if you do like a consult on a patient, they no-show, can you guys convert them to e-consults?
Usually for consults, it's like they're already in the hospital, so I don't think I personally have never encountered a situation like that.
But you guys but like in clinic though, like you guys have consults, right?
Oh, yeah. Sorry, like new patient consults, yes.
Yeah, and if they no-show, are you able to, is that allowed? Like, do you guys ever convert them to e-consults?
No, not to my knowledge.
Well, we get away with it here. So, I'd already put in the time, reviewed the chart on this patient, waiting for them to show up. Pretty classic hypothyroid, some mental health stuff, fibromyalgia with the associated knee, back, neck pain. All interestingly, hysterectomy, hypertension, migraine headaches, acid reflux, we already mentioned that, and neuropathy, and body mass index of 44. And I think with the body mass index being that high, I was kind of concerned about risk for CO2 retention, but the serial bicarbs were less than 28. So 28 is like my cutoff for, concern about CO2 retention. And there was no PFT on file to indicate whether there was restrictive lung disease. So I actually, seeing the writing on the wall that this patient at least needed some sleep study, decided that, she'd be acceptable for a home sleep test. And I recommended home sleep test followed by auto CPAP with close follow-up with me. And to get her in, I offered a 30-minute clinic slot. So I think shortly after that, the home sleep test got done. It was positive. And we send out a results letter, ordered CPAP, but for whatever reason, she got dropped into a 15-minute phone slot for her first appointment with me. So not exactly ideal for talking about any other sleep problems, but she was really not happy during that visit. She never got the letter. Also was unhappy that she never got set up with CPAP. This is 3 months later, I think, or 2.5 months later. So majority of that visit was discussing the results, apologizing for our problems in our sleep clinic, and essentially got a little bit of history on her snoring. She's got insomnia, waking up every night, every hour, feels unrested. There's not really a consistent bed partner, I think, at the time, but she had sleep problems since boot camp in the late 90s. So 20 years of sleep problems, positive sleep study. A lot of these patients in my clinic, at least, that present with insomnia have sleep apnea, at least 80% of them. So at that visit, it was just like, hey, let's try the CPAP and see how things go. The other thing I didn't show you here was that essentially she's a frequent flyer at the hospital. There's like 2,000 encounters in the last 20 years. So there's just a lot of stuff in the chart on her. So we put on CPAP, and actually I see her a couple months later, and she's doing really well. Her Epworth's resolved. I notice on screening that she has some nightmares on her screen, and we actually get to put her through our clinic instead of just like an e-consultant phone. But she ends up as in kind of like this return visit clinic, so I don't get to do my typical questionnaire we do on them. But her compliance is pretty good for someone who just got on auto CPAP and flew. So I was kind of impressed. At that visit, we finally get to talk a little more. She's had nightmares since childhood, at least 2 to 3 times a week, severity 5 out of 10. She can't recall the content, but it's not recurrent content. And that's, I don't know how you guys manage nightmares at your facility, but I ask about recurrent content because those are good patients for dream rescripting, which we have access to here. And I don't know if you guys have access to that. Feel free to jump in. Anyway, so at this point, though, I do use a lot of alpha blockers for managing nightmares, but typically, in certain cases, I'm more reserved in using them. They've been there for 50 years at this point. There's no real pressure to fix them. They're not every night, though. I'd rate these at least mild to moderate severity in the sense of overall how severely she's affected to them and how much they're contributing to the insomnia. So I actually like to use doxazosin. I know that's not as popular as prazosin in the literature, but it has a longer half-life, and I see fewer side effects with it. So we discussed doxazosin at this visit, but we didn't start it. She's going to have a bariatric surgery in the next 2 months, so there's no pressure that we need to fix anything. I just left her with the knowledge that as you lose weight, we may need to reduce the pressures on you. It's not, if you saw her download, the 95th percentile was like 10, so it wasn't extremely high, but we just left it alone since she was compliant. And then, the acid reflux, she was told that was going to be resolved with surgery. I left that alone. She was already on omeprazole. I don't know, when I see follow-up patients, I go through like the same 5 review systems of whether, there's any weight changes, if there's any nightmares, if there's any acid reflux, urination, or nasal congestion disturbing their sleep. And that typically helps me manage these patients. If the acid reflux is more than 2-3 times a week disturbing their sleep, I typically treat it with an acid blocker. And beyond that, I defer to the primary care doctor to start the GI workup. But that's usually where I intervene there if the CPAP doesn't resolve it and so forth. But in this case, she was already on an acid blocker. She's on the CPAP at this point, and that hasn't resolved it. So we're just going to wait to see how this surgery plays out. At this visit, also it was identified that she had urination frequent 4 to 5 times a night. This could be due to undertreated sleep apnea, but again, I screen for alcohol use and fluids in the evening. She drinks Kool-Aid, kind of odd. I don't know how much, but there was no, the hemoglobin A1C was 5, so there's no diabetes, so I wasn't worried about some glucosuria. So essentially, I just deferred it to her primary doctor at this point because the sleep apnea was treated, so it could be something more than I think that I can handle it from a sleep medicine standpoint. So let's see. She's going to have the bariatric surgery in a couple months. She has it in March, and then I see her in September. Okay, so this is kind of a visit where I found out actually she was service connected for PTSD, though it wasn't on her chart. And so more stuff starts coming out. And she's still compliant with the CPAP, but she feels now that the pressures are too much. She's lost, 60 pounds? And so that's a pretty rapid weight loss. And so we kind of, as far as the pressures, adjust them a little bit and move on there, mostly because she was still complaining of chronic insomnia. So I thought, well, maybe the pressures aren't starting up fast enough for her to fall asleep. So I tightened them up a little bit. She had been put on trazodone over this point, not by me, but it was causing grogginess. So we discontinued that. And obviously that's something that's pretty common with trazodone. At this point is like, she's had the insomnia for 20 years, probably should get some CBTI coaching. So that takes months to go in. So I put that in. And the nightmares, we see this a lot in primary care. Well, not a lot, but even though they've consulted us, they sometimes jump in and start adding medications. So prazosin was added, but she had hypotension. So we stopped it and I switched her to doxazosin. So the acid reflux that we've been watching resolved with the weight loss after the surgery. And the urination also, apparently, after she quit the Kool-Aid in the evening, and maybe the effect of the weight loss, though, didn't make much difference. So again, I deferred that to the primary doctor, but nothing had really changed with that. So that was September. I followed up with her a few months later in February. So now she's been on CPAP for a year. Her compliance is excellent, but she finds the pressure is too much and she's still struggling with insomnia. However, when you talk to her about the insomnia, her sleep onset latency is 30 to 45 minutes and she's only waking up 2 or 3 times a night. So in my book, that's an improvement from where she was to begin with. Blood pressure's okay on the doxazosin. The nightmares have improved now by pretty much 50%. So once every 3 weeks and a 2 out of 10 severity. No side effects to the medication. That's kind of how I do a lot of phone follow-ups when I'm treating someone with nightmares, because they're just quick. You're touching base. How bad are the nightmares? Okay, with just a dose escalation, usually very gradual, every month or 2 months. So that's usually how I manage that. She hasn't done the CBT for insomnia. It's pending for a couple months from now. And for some reason, the acid reflux and the urination just resolved on their own suddenly. I don't know. Doesn't make any sense to me. I mean, the acid reflux had already resolved, but the urination just went away. So for the most part, I think this is pretty good for as far as where she started. But a couple months go by, we talk again to follow up on the nightmares. Now she feels like the CPAP is disrupting her sleep. Now, we've had pretty good compliance, but now it's disrupting her sleep. And she's avoiding sleeping on her back. She's just sleeping on her side. And so we discussed that, hey, if you lose enough weight, you could have resolved the sleep apnea. We only had the home sleep test to begin with. And you guys can stop me because this goes on for a long time. Anyway, so we decide that let's do a sleep study to see if there's really any residual sleep apnea that we're treating at this point with. Let's see, she's lost over 100 pounds of weight. So it's possible it's cured. In my clinic, typically it's not cured with weight loss, but in maybe you guys see it differently, but it improves, but it's typically rarely cured. So anyways, she decided not to go to CBT for insomnia, doesn't need it anymore. And all these chronic medical urination, nightmares, acid reflux are resolved. She's still on the doxazosin at 2 milligrams. Okay, so we get a sleep study. You can see the delay here. Ordered in March or April, gets done in August. This is pretty classic for us here. Pretty much sleep apnea just on her back, mild too on her back. So, I recommend to her, essentially you can use the CPAP if you can't avoid sleeping on your back. But if, as you told me 4 months ago, you've been sleeping on your side, you feel like you don't need it, great. We also noticed that there was a lot of PLMs on this, and not always with arousal, but there's a lot of leg movements. And so, as you can see from my history here, e-consult to a phone visit to a follow-up, I never really backtracked on some of the things like her neuropathy to kind of look in to do how I typically do with the full consult to talk about restless legs. I never did that. And so, we look back at her, I call her and I look back at her iron studies, and she's pretty much been borderline anemic for 10 years. Okay, dipping between under 12, above 12, back and forth. And the ferritin, in 2022 is actually 45. It actually was as low as 15 back in like 2012. So again, not great clinically on my part, because I never did that full consult. And this is where you can get in trouble with e-consults and trying to squeeze patients into a 15-minute phone visit and then a follow-up and so forth. So yes, not the best management on my part, but we, so we're talking, and she's, I don't know how you guys have a problem with this, but patients with neuropathy, she was actually had been on, the neuropathy wasn't even on a problem list, but she was on gabapentin. And I think I had assumed, we see it often for mental health stuff, so I probably wrongly assumed that it was on there for mental health stuff. But she's kind of non-specific in like when the neuropathy started and why it was a problem or how it was affecting her sleep. But at the end of the day, she was already taking an iron supplement over the counter that also was not on her medication list. And so we just decided that, she was having some constipation from that. We just decided that it's just better to infuse, mostly because infusions at the VA are actually pretty easy to get. So it's like constipation, low iron, borderline anemic, boom, iron infusion, which typically makes people feel pretty good pretty quick. So at that visit also, though, she's like, I'm not going to use the CPAP. I'm just going to avoid sleeping on my back. Okay, so we left it at that. So I followed up with her a month later. There's been some social changes. She moved in with her brother to help care for her aging parents. Now there's noise from neighbors disturbing her sleep. CPAP compliance. We didn't expect it to be good because she said she was going to avoid using it, but essentially not using. I really can't tell at this point if she's got PLMs or neuropathy or true restless legs. She's just kind of all over the place with symptoms. But she did feel improved after the infusion. She still sleeps alone, so she can't comment if there's still leg movements disturbing her sleep. The ferritin's improved to 82. And she decides, despite the constipation, that she wants to remain on her iron supplement. So we add ascorbic acid. So a lot of times I will always use ascorbic acid with oral iron in my practice. I think it does help. When I've tried over the years to not use vitamin C with the iron supplement, it doesn't replete at all, or it doesn't at least do maintenance levels even. So we just leave it at that. And at this time, she starts complaining of hypersomnia. She reported, sleeping like 3 hours per night. She was a pharmacist, worried about making mistakes. But really, at this point, I just said, you need to get enough sleep. I didn't put her on any medications, but knowing her mental health history, I thought maybe modafinil might be a good choice. But again, didn't do anything different. And then for the environmental sleep disturbance, white noise, earbuds, stuff like that. But I don't know, new stuff just keeps coming with this gal. And I don't know how you guys, deal with that or keep track of it. But so I call her a few months, like 4 months later, ongoing fatigue, not sleeping well. Now she reports classic RLS symptoms, despite the gabapentin, the ascorbic acid, and the iron. At this time, she's also diagnosed with pulmonary hypertension. So we decided, I think she had been told by pulmonary to resume auto CPAP, but she felt smothered. So I lowered the pressures for her, 6 to 10. And, oops, did I mess up the order here? 1 second. Okay, sorry, I went back to. Meanwhile, someone decides to put her on Flomax for kidney stones. So she's a pharmacist, so she secure messages me, and she's worried about an interaction, so we stopped that. But we often see this with doxazosine, is that people either ignore it or they stop it for the wrong reasons, because they could, if they were concerned, they could have just increased the dose, because it has the same effect on the bladder as in the prostate. She's not a prostate, obviously, but it can be used for kidney stones and stuff like that. Now, I've never used it in women for kidney stones, but again, so it was stopped. And so I see her back in June. Now she's working 66 hours or more a week and sleeping more. She's compliant with her CPAP, but still waking up feeling smothered. And now she's drinking caffeine up until bedtime. So acid reflux has returned, urination has returned, it's problematic. Her primary care doctor added ropinirole. It's 2023. So, I don't think the new guidelines had really been out yet, but so we saw that. So essentially, I decided it's time to titrate the patient. She's got pulmonary hypertension, pressure intolerance. Let's just figure out what we're dealing with. Asked her to cut out the caffeine because it's contributing to the restless legs, the acid reflux, and the urination. And we weaned the ropinirole, ordered some iron studies to check up on the iron levels, which she forgot to do. And just general, asked her to use the CPAP enough and get enough sleep, which she wasn't doing either. So we get the iron labs back. So the maintenance of the iron on the oral supplement with the ascorbic acid was effective. It's around 100. So we'll take it. The hemoglobin's adequate. So we didn't do an infusion. We do the titration. It's kind of mixed results. Essentially there's some subtle airflow limitation, both in supine and lateral, but so we put her on 9 to 20. That should say probably follow-up February. So I see her back last year, doesn't tolerate the new pressure settings, even though they're not crazy from where she was in the past. She has an upper respiratory infection, doesn't want to resume PAP at all. We discussed alternatives. She wants to think about Oxide-OSA. I gave her the handout, left her alone. Restless legs is now under control. Iron level is 141. She's remaining on the gabapentin, the iron supplement. The acid reflux urination resolved with cutting out the caffeine. I didn't put on here. She's got nightmares, but they're resolved on the doxazosine. Okay, so I talked to her a couple months later after she's had some time to review Oxide-OSA. Remember, she can just avoid sleeping on her back, but that's not going to work for her. She decides she doesn't want to do the Oxide-OSA at all now. She wants to focus on weight loss and a dental device. So I sent her to Detroit VA for a dental device. And I just saw her this week. She's using the dental device, but sleeps alone, so doesn't know if she's still snoring. Now she's waking up every hour again, has acid reflux urination and restless leg symptoms. She's also drinking 3 Mountain Dews up until bedtime. Right up until bedtime. I advised her to stop, but she refuses. I offered a repeat study to determine the efficacy of the dental device, but she's unhappy with all her care now and states that all we do is put her on medications and no longer wants to see sleep medicine. So so kind of a frustrating case when you've done a lot of work for someone, but also kind of outlines some of the relationships that we have that, some of these problems they have with their sleep are self-inflicted. And, if the patient's not willing to give up some things like Mountain Dew in the afternoon or Kool-Aid or whatever it was, it's hard to fix them. Sorry, Ron, I didn't see your hand raised there.
I just raised it.
yeah.
Thank you for putting that saga together. I mean, you've obviously done a lot over time to try and help her in multiple directions. Are you submitting this to the casebook where they're asking for cases, or you figure it'll take too many chapters?
Well, I didn't know about if it was be appropriate, or I didn't know about the case, but I mean, like this isn't that uncommon. Like I've got guys that we've been back and forth for a decade now, but we can talk about, if you think it'd be a good case for that. But it's sometimes whack-a-mole with people, even
That's
when
what
you
you
have,
gotta call it. Call it
Yeah.
whack-a-mole.
I
Whack-a-mole.
mean, and I mean, it cracked me up yesterday because we've done a lot of work here, and I didn't actually put her on that many. I put her on one medication as far as I could tell, and so I did a few iron infusions, and ascorbic acid, I guess. But essentially, I don't use a lot of medications on people. But anyway, so
Well, let me ask you, seriously, I usually don't have such success with the iron, but if I did, when I got to a ferritin of I don't forgot, 125, 150, I'd probably take them off because I'd be worried that they'll just continue too long and get iron overload. I know that's not close to iron overload, but she was consistently increasing.
yeah,
What-
she was. But I tell you, I've never seen anyone get iron overload from a supplement. And knowing how on and off she was, I wasn't too worried about her that. Now Dr. Burkowski will say that, once you saturate that, the regulation for absorption will downregulate. And I'm not as technical as him. He could tell you exactly what that is. And he'll even say do it iron every other day is better than every day. And
That's right. Absorption is supposed to be better every other day.
correct. Now, the reason I tell some patients every day is because if I tell them every other day, they might take it once a week. It depends on the
I
patient.
totally understand.
Yeah. So in our population, they're not the most reliable. So they make you laugh sometimes. So I don't know with her, because she'd been on that iron supplement supposedly for years, and so we added the ascorbic acid. But even then, since I've been managing her for 5 years now, the way I handle iron now versus then has changed as well, right? Like as far as not looking back at it yesterday, yeah, maybe I should have told her every other day. But things had kind of been stable, so I kind of left it alone. But I think we start worried about iron overload when it's over 200, or is it 400? Like how far do I have to go at this point? I'll have to check. But yeah, I'll look. I don't think she was just frustrated yesterday. I think she's going to circle back and go from there. But
I think Farouz put in the chat that the receptors, the hepcidin receptors. But
that's the one on the test. Yep.
John, I think you should have claimed victory early on and then just.
I
stop
probably should
there.
have. Yeah.
Maybe.
Yeah. Well, she doesn't but she's a moving target. She lost all that weight, and then should have been easy, but yeah, doesn't always work like that. And you guys probably seeing this too now, where we're seeing just as many patients, if not more, because they're losing weight and they want to be reevaluated. They're losing weight on Ozempic, or most of mine are on Ozempic. They're not on tirzepatide yet, but so now we're restudying them again and again and again. One study to prove that they still have it, another study to find the pressures that they don't think they need.
I think you did a good job of highlighting when we've been following patients longitudinally for quite a while, how issues evolve over time, right? And sometimes you need to zoom out and take a step back at because it can be easy for someone you've been following longitudinally for a while to just kind of think in one box. And that can be challenging in chronic disease management.
Well, I think looking back, I should have seen ahead of time that this was going to be more of a challenge than I thought, and that e-consult probably was not appropriate, knowing that she had 2,000 encounters in 20 years. And so sometimes you need to just read the room. This was not going to be a straightforward, easy one. And then just stuff just kept coming up. And in the end, even if you resolve those issues, they still some people don't want to be fixed, I think. So, you just had to quit drinking Mountain Dew and 3 of your problems will be fixed. So that's it.
Nor is it always straightforward for them to, right? It's so intertwined with a lot of complexity for patients too.
Yep. I didn't do a good job of looking at her medication list when she first came in either, because I didn't have the normal consult build. And so that's another problem with this case is that, I might have asked more questions about this, and this, which I didn't. So you gotta be careful when you're trying to wing it, even if you feel like you're confident about what you do, you can screw up. So that's a learning lesson. That's all I got for you. I gotta get back to clinic.
Thank
Hope that-
you. Yeah, thanks, John. All right, see you all next week.